Поки професор підтверджує, поки наша команда зв'язується з професором, щоб підтвердити, чи він мене чує, чи ні, я його представлю і представлю нашу програму, щоб ми не втрачали час, бо вже так час пізній, вже 7 година 14 хвилин. І так, в нас сьогодні нашим спікером буде професор Dimitris Anagnostopoulos. Він з Греції, з Афін, з Каподистрійського університету. Він професор дитячої та підліткової психіатрії Національного Каподистрійського університету Афін в Греції. Це фахівець з майже 40-річним клінічним і академічним досвідом у сфері психіатрії, дитячої та підліткової психіатрії та психоаналітичної психотерапії. І його професійна діяльність охоплює розвиток системи психічного здоров'я дітей і підлітків у Греції, викладання у медичних освітніх програмах, а також дослідження у сферах розладів розвитку, психічного здоров'я мігрантів, громадської психіатрії та психотерапії дітей і підлітків. І нашою сьогоднішньою темою буде психоаналітичний підхід у роботі з травмою. Тема дуже важлива, але нам треба точно знати, що професор нас чує, а ми чуємо його. Знаю, що нас дуже багато. Чи ми можемо попросити перекладачів, попросити спікера, якщо він їх почує або мене почує, перейти в англійський режим на каналі? О! Can you please possibly change your channel to English in Zoom, because there is a channel. Can you please change your channel in Zoom for English? Because you can touch the button and you change your channel and you will hear the interpreters.
Yes, I put it in English. Listen in your...
And you don't.
No. I put it in English. Okay. Okay, I'm staying here, yes. Okay.
Добре. Тобто, я сподіваюся, зараз перекладачі нам підтвердять, що професор нас чує і вже чує переклад на англійську. Вірно? Добре. Тоді ми будемо починати нашу презентацію, і тоді ми просимо професора почати нашу презентацію і вивести його на екран. Дякую.
No, now it's my turn. I can start my presentation. Okay, thank you very much. Thank you very much. First of all, I would like to say a great thank you for the invitation. I'm honored. I see that there are almost 370 people now connected in the Zoom. That makes me feel a little bit, I have to do something to please all these and to be for their kindness to be with us. So thank you very much for being here today. Thank you that you are all interested in this psychoanalytic approach to trauma. Maybe you can it might be reasonable for you to ask, after 3 actually excellent sessions devoted to PSD, why again speak about trauma? The answer is simple in my mind. May I have the second slide, please? Can you hear me? Okay. This is the outline of my presentation. As you can see, there are 3. I cannot see my slide clearly, but there are 7 main parts. Of course, the biggest part refers to the psychoanalytic cause of trauma, but I will start with some first introductory comments, And may I have the second, the next slide, please? And this is the central question: trauma beyond PTSD, psychoanalytic perspective, beyond diagnostic classification towards structural symbolic understanding. And as I said, it is logical to wonder why, following, as I said, 3 excellent webinars on PTSD, now we're convening a 4th on trauma. The reason is that the concept of psychic trauma exceeds the diagnostic category of PTSD, which is primarily concerned with the recording of symptoms and their associations with specific potentially traumatic symptoms and experiences, criterion A by DSM-5. But as mental health professionals, our interest extends beyond diagnostic classification to the internal functioning of the psychic apparatus and the processes through which symptoms are constituted. So, PTSD describes symptom configurations. Psychoanalysis investigates the internal transformation or failures of transformations of traumatic stimuli into psychic meaning. These distinctions becomes crucial when we move from trauma-related disorder to severe personality pathology, psychosomatic conditions, or psychotic organizations. In my mind, the psychodynamic psychoanalytic approach to trauma contributes to a more comprehensive understanding of trauma as a major biopsychosocial nosological entity of great interest in our times. In other words, when we speak about trauma today, you usually refer to exposure to an overwhelming event, such as war, accident, abuse, disaster, pandemic, and we access symptom clusters, measure distress, evaluate functional impairment, and rightly so. But clinical experience may have the other slide. Sorry for that, but unfortunately, it was this technical problem which does not permit me to conduct my slides by myself. The other one, please. Thank you. The next one. Yes, this is the clinical paradox. Yes. As I said, our clinical experience today repeatedly confronts us with a disturbing observation, the clinical paradox. 2 individuals, for example, may be exposed to the same external event, and yet their psychic outcomes differ radically. One develops, for example, intrusive memories, but retains structural coherence. Another one develops chronic relational instability. Another somatizes. Another decompensates psychotically. Other collapses silently into emptiness. If the event were sufficient to explain trauma, outcomes would be more uniform. They are not. This observation compels us to ask a different question. Not only what happened, but also what occurred within the psychic apparatus when it happened. The psychoanalytic perspective does not replace, of course, diagnostic systems, nor does it oppose neuroscience, of course. But it introduces a structural question. Was the traumatic excitation symbolized, or did it remain unbound? Was trauma integrated into narrative history, or did it persist as repetition without representation? In other words, trauma may be understood not only as an event that overwhelms the psyche and its function, namely the ego integrity, but as a rupture in the capacity to transform experience into meaning. This brings us to what I consider the decisive question. The question is not only what happened, but whether what happened could be symbolized. Today, I would like to explore and discuss with you this structural dimension of trauma beyond PTSD, consider how it may complement diagnostic and neurobiological approaches. Trauma is not defined only by the magnitude of the event, but the fate of traumatic excitation within the psychic apparatus. The next slide, please. From somatic good to psychic breach. As maybe you know already, the term trauma, originates in ancient Greek from titrosko, referring to bodily rupture. In the Iliad, Homer describes survivor guilt and psychic devastation after war. Later, in Rome, Lucretius later refers to the re-experiencing of battle in dreams. You see, even from the ancient Greek and Roman, we have descriptions of what we call today as symptoms of PTSD or trauma pathology. And this is true for the ancients, Greek and Romans. But the term entered English medical language only in the 17th century, originally referring strictly to wounds. So psychoanalysts transferred the concept from the somatic to the psychic register. Trauma became not simply an event, but an internal rupture in the continuity of psychic functioning. But beyond psychoanalysis as well, through multiple semantic shifts, trauma as event and experience became the favorite term used by Western men when referring to the misfortunes that mark his individual and social life. Thus, its consequences became inevitably linked with collective painful experience of war, catastrophes, genocides, and multiple forms of violence that continue to characterize contemporary civilization. Contemporary art, an entire field of literature, especially the novel,
Dimitris, you are muted now. You are muted, Dimitris.
You didn't hear anything? From which point?
Just the last 30 seconds. Hi, Dimitris.
Okay, hi, Jörg. Thank you. Thank you. You managed to be here with us. Thank you. I'm very proud and honored. So I have to go back from somatic to bridge. It's okay? Because automatically this happened. I did nothing for being muted. So, okay. Okay. So okay. The modern. Okay. No problem for that. It's not so semantic that. Okay. Contemporary, as I said, bear witness to this through various forms of art. What I could say is that it is a deeply rooted experience trauma, inscribed one, as I said, even in the collective unconscious of humankind. The next slide, please. The psychoanalytic concept of trauma. the concept of trauma is one of the fundamental psychoanalytic concepts, running through almost the entirety of psychoanalytic work from its inception to the present day, having undergone various modifications throughout this course. In psychoanalytic theory, trauma refers to an event or experience that overwhelms the psyche's capacity to process, symbolize, or integrate stimulation. Trauma occurs when an influx of excitation exceeds the subject's protective shield, resulting in a breach of psychic defenses. The traumatic event is not fully assimilated into conscious memory. Instead, it persists as an unbound, intrusive element within the unconscious, often returning in symptoms, dreams, or repetitive enactments. Trauma is thus defined less by the objective severity of the event and more by the subject's inability to psychically bind and represent the experience. In traumatic situations, the psyche is unable to represent and to attribute meaning to these traumatic stimulation excitations, with the result that a loss of meaning occurs. At the heart of every psychic traumatization lies the experience of the psychic annihilation of the subject. However, what are the destinies of the traumatic within psychic life and in the various phases of the individual's development, from early childhood to old age? How are they created? To what extent can the psychic apparatus transform traumatic reality? What form and what position do traumas take within the psyche? How are they encountered in psychoanalytic experience and in the theoretical clinical field? How are they related to objects of care? What is their treatment? Actually, these are the questions I will try to attempt and I will try to illuminate through the prism of the psychoanalytic approach. Now, regarding the initial psychoanalytic conception of trauma. According to the initial psychoanalytic view, trauma is excessive excitation that can neither be discharged toward the motor pathways, nor integrated through associations, nor overcome through the work of memory. In its historical development, the elaboration of the concept of trauma is extremely broad, with many branches upon which different psychoanalytic schools have focused. In psychoanalytic theory, trauma is not defined solely as an external event, but as an experience that exceeds the psyche's capacity to process and symbolically integrate it. Trauma is inscribed in the psychic apparatus in a manner that disturbs ego functioning and re-emerges through symptoms, repetitions, and disturbances in relationships. The next slide, please. Examining historically the evolution of the concept of trauma in the thought of Sigmund Freud, we identify the following milestones. During the early years of psychoanalysis, Freud attributed the etiology of hysteria and the neurosis to traumatic experiences of childhood. In 1992, during and after the First World War, and because of what happened at that time, Freud re-examining the concept of trauma, he linked trauma with the mechanism of repetition compulsion and by extension with the death drive. Later, in 1926, he emphasized the interaction of external and internal factors in the creation of trauma, indicating the Oedipus complex as a traumatic paradigm. Finally, shortly before his death in 1939, he linked trauma with the narcissism. In summary, we could say that Freud introduced the concept of trauma as the result of an excessive influx of stimuli that breaches the protective shield of the psyche. In Beyond the Principle, 1920, he described it the phenomenon of repetition compulsion, according to which the traumatic experience returns not as a memory, but as an action or symptom. Trauma there is associated with unbound anxiety that cannot be psychically contained, leading to pathologically defensive formations. Next slide, please. Now we'll go to the contribution of other psychoanalysts to the theory of psychoanalytic trauma. Actually, along with Freud, other psychoanalysts contributed significantly to trauma theory. First of all, Melanie Klein. In the work of Melanie Klein, trauma is conceptualized not primarily as a single, overwhelming external event, but as rooted in early anxieties connected to persecutory and depressive positions. Traumatic experience emerges when primitive anxieties linked to fears of annihilation, fragmentation, or loss of the internal good object overwhelm the infant's capacity for integration. Unlike Freud's emphasis on the breach caused by excessive stimulation, Klein situates trauma within the dynamics of internal object relations, particularly the failure to integrate love and aggression toward the same object. For Donald Winnicott, trauma does not primarily stem from an excess of drive stimulation, but from failures in the facilitating environment. Psychic development depends on a good enough mother who provides holding, reliability, and adaptive responsiveness to the infant's needs. When this environment fails, especially in early preverbal stages, the infant experiences not conflict but impingement, a disruption of spontaneous being. In Winnicott's framework, trauma is linked to breakdown of holding, the infant feels unprotected and exposed, impingement, external demands intrude upon the infant's emerging self, false self-formation, the child defensively organized around compliance in response to environmental failure. Unlike Freud, who emphasized economic excess, or Bion, who focused, as I said later, on failures of containment and symbolization, Winnicott locates trauma in environmental failure occurring before the ego is sufficiently integrated. Early trauma, therefore, lead not to repression of conflict, but to a more fundamental disturbance in the continuity of being. For Wilfred Bion, trauma is not defined primarily as an excess of stimulation, as in Freud's economy model again, but rather as a failure in the transformation of emotional experience. Central to this formulation is the concept of the alpha function, the capacity, initially performed by the mother, to transform raw sensory and affective data, beta elements, into thinkable, symbolizable mental content, alpha elements. This process depends upon containment, the caregiver's ability to receive, metabolize, and return the infant's projected anxieties in a modified and tolerable form. Trauma, from a Bionian perspective, occurs when containment fails and emotional experience cannot be transformed into thought. Unprocessed beta elements remain unmentalized and may later return as psychotic anxieties, somatic disturbances, or states that resist symbolization. Trauma, therefore, is understood not simply as overwhelming stimulation, but as experience that cannot be thought or psychically integrated. For Jacques Lacan, trauma is located within the register of the real, which resists symbolization. Trauma cannot be fully integrated into language and returns as rupture in speech, desire, and the subject's relation to the other. Psychoanalytic work does not aim at eliminating trauma, but at transforming the subject's position in relation to it. For Salvatore Ferenczi, trauma is not merely the result of overwhelming excitation, again, but emerges fundamentally with a relational context of betrayal and disavowal. In his seminal paper, Confusion of Togis Between Adults and the Child, 1933, Ferenczi argues that trauma occurs when an adult imposes passion or violence upon a child who operates in the language of tenderness. The traumatic impact is intensified when the adult subsequently denies or minimizes the event, forcing the child into identification with the aggressor. Unlike Freud's emphasis on repression and internal conflict, Ferenczi highlights the devastating effect of disavowal. The child's reality is invalidated, leading to fragmentation of the self and splitting. Trauma thus involves not only the injurious event itself, but the collapse of trust in the caregiver. So, in this way, Ferenczi also introduces the idea that trauma produces a form of premature maturity in which the child defensively assumes responsibility or hyper-attunement in order to survive relational breakdown. In this view, trauma is fundamentally interpersonal, rooted in asymmetry of power, betrayal, and the impossibility of symbolizing experience within a trustworthy relational field. Contemporary psychoanalytic trauma theory now has moved beyond the classical understanding of trauma as a single catastrophic event defined by excess stimulation. While early formulations emphasized economic breach and the failure to bind excitation, more recent approaches conceptualize trauma as a disturbance in relational, representational, and structural processes. Influenced by object relations and post-Kleinian thought, trauma is increasingly understood as emerging from chronic failures of attunement, containment, and affect regulation with early caregiving relationships. Rather than being fully repressed, traumatic experience may remain unmentalized, incapable of symbolic representation, and thus return through enactment, somatic expression, or repetition. Across these perspectives, trauma is no longer conceived solely as an external event, but as a breakdown in the processes that render experience meaningful, representable, and psychically integrated. Contemporary approaches such as mentalization theory and neuropsychoanalysis integrate classical psychoanalytic concepts with findings from developmental psychology and neuroscience. Trauma now is understood as the result of disrupted early relationships that affect both symbolic functioning and neurobiological development. The next slide, please. So after this short review of the concept of trauma, the first thing that I have to underline is that psychoanalysis situates trauma in two temporal moments. In the infantile childhood, time and in a later continence time, a more or less adult time, in which trauma is produced retroactively. As regards childhood trauma, many factors cause it: maltreatment, violence, neglect, lack of understanding, sexual excitation, and absence of care and parental structuring. The retroactive production of trauma is not a simple reproduction of the initial latent trauma. Laplace and Bodalis, emphasizing the notion of après-coup, pointed out that the second moment does not retrieve a traumatic experience that remained latent and merely reveal it to consciousness. On the contrary, the circumstances of the second moment gives meaning and determines the significance of the first moment. It is not a deferred action of the past upon the present, but a retroactive action of the present, that is, of the current traumatic experience, upon the past, upon the memory traces of the past, where past and future mutually shape one another within a concept of dialectical causality and mutual influence each other in terms of meaning, structuring the present. Often there is not one trauma, but a combination of traumatic situations that act cumulatively upon the psyche. Next slide, please. From boring bonding to acting of excitation. Brainerd and Freud, 1895, initially viewed traumatic memory as a foreign body within the psychic tissue that unfolds its effect there until, through therapy, its emotional recollection and discards take place. Later, Freud described this foreign body as a quantity of excitation that cannot be psychically bound, that overwhelms the ego, and that leads it into a state beyond the pleasure principle. Repetition compulsion emerged as an attempt to bind the traumatic excitation by bringing the traumatic experience back to the foreground in an effort to control it, with the aim of returning to the functioning of the pleasure and pleasure principle. Next slide, please. The significance of the pleasure and pleasure principle and repetition compulsion function. The functioning of the pleasure and pleasure principle and repetition compulsion constitute the main conceptual tools in distinguishing between a traumatic situation of lesser severity, which leads to psychoneurosis, and trauma that leads to a chronic traumatic pathology, equivalent to what Willy Berazet and colleagues call poor trauma, or to psychopathology structurally equivalent in terms of psychic organization, that is borderline condition, psychosomatic phenomena, fate neurosis or failure neurosis, accident pronesis, to name some of them. In psychoneurosis, the childhood traumatic situation through repression and under the pleasure and pleasure principle is warded off and leads to the formation of neurotic symptoms. In pure trauma, however, a rupture occurs in the pleasure principle and we are led to traumatic pathology. In psychoneurosis, the traces of the traumatic situation can be located through lifting repression and the return of the repressed material from the dynamic unconscious, a signal anxiety there predominates. In the case of poor traumatic situation, where automatic anxiety predominates, and the coequivalent pathologies mentioned above, explicit memory traces do not appear to exist. In clinical work with such traumatic situations, we encounter psychic elements described as foreign bodies for the ego. These are very elementary psychic inscriptions which, either due to the prematurity of the stimuli or due to their intensity, exceed at the moment the ego's capacity for symbolization and remain non-representative outside the significance of language. They consist of images, bodily sensations, somatosensory elements, sounds, traces that remain very close to perception and do not enter associative chains, do not actually in free association function. Thus, these traumatic traces are not integrated into narrative memory and form what neuroscientists call implicit or non-declarative memory. Traumatic memories are isolated from the rest of psychic material and encapsulated, lose the possibility of adaptation either through associated connections due to new experiences or through repression. Next slide, please. Willy Bergent and colleagues claim that all neuroses are ultimately traumatic neuroses with the following difference. Psychoneuroses are traumas with history, whereas poor actual neuroses are ahistorical traumas, or more precisely, white zones with little possibility of historization in subjects whose personal history is substantially poor. What is of interest in our discussion is that the infant's automatic emotional responses toward the significant other, the early emotional experiences with the other, are related to non-narrative implicit memory, and that all this knowledge of ways of being with others, while not conscious, is not repressed either, and there is no possibility of verbalizing it or subsuming it under explicit memory. Thus, there exists an unconscious that is not the result of repression, but is organized in the form of automatic processes where memories appear as disconnected or split in the same sense that while they influence behavior and constitute behavioral patterns, there is no possibility of processing or verbalizing them. Thinking from this perspective about Freud's concept of repetition in place of remembering, we would link trauma with repetition as a specific type of memory, that is, memory through action. Thus, our patients come to us unable to narrate their traumatic experiences. What they do is repeat them in therapy with us or allow these implicit experiences to emerge in the same form in which they are stored, namely as procedural behaviors. And since they are also stored as perceptual traces, somatosensory elements, disconnected images, emotional states, bodily sensations, as well as smell and sounds, they are expected to come to the foreground as such. Next slide, please. Yes, this is the next line. Okay. Now I will say a few more sentences, and I will try then to go to the end of my presentations because of the time. I see that we have only 35 minutes and we have to leave at least half an hour for questions, as I have been instructed by our hosts today. But I would like to say a few more sentences about these crucial distinctions between positive trauma and negative trauma. Positive trauma and its therapeutic significance. Positive psychic trauma is caused by injuries of lesser severity, so that it can be retained with the psyche as a foreign body in the form of representations. For this reason, it is also recognized as represented trauma. More specifically, the injury leaves an imprint with the inscription of memory traces. This material, under the pleasure principle, is repressed into the dynamic unconscious. There, it acquires the form of representations and becomes linked in chains of meaning, which maintain a continuous presence in the mind and can become the object of thought for the subject. In every case in therapy, says Andre Green, as in the beginning of life, the creation and knowledge of the self is mediated, go through others, initially mother and father, and later the therapist. We need one another, an external object which will host with its own psyche the disordered elements that we present to it. The other will allow our fragments to exist because it will receive them within itself and then understand them, reflect upon them, and interpret them to us. The other returns them to us, and then we can return to ourselves and reflect. If there is no one to receive them, what we externalize falls dead into the void. If someone hears them, understands them, and returns them to us, then they are revived. As Aristotle put it, the act of understanding is life, and is a crucial element of our everyday practice as child adolescent mental health professionals. In the treatment of positive trauma now, within the richness of this intersubjective relationship and the interactions of transference and counter-transference, the traces, representations, in this case, of the traumatic situation can be located through the lifting of the repressed material and its return from the dynamic unconscious into consciousness. This will lead to their synthesis into a life scenario far more elaborated and closer to the real history of the patient. For positive traumas are traumas with history. The patient himself, recovering this lost part, becomes the subject of his history and ultimately of his own life. Now, let's go to negative trauma and its therapeutic significance. Today, however, in our work, we increasingly encounter the consequences of violent and early traumatization, what are defined today as negative traumas, as non-represented. The traumatic experience causes an influx of stimuli excitations that is considered excessive in comparison with the individual's degree of tolerance and his capacity to control and psychically process them. Consequently, a rupture of the protective system of the psyche occurs. The foreign body, in this case of negative trauma, is not an inscription of memory traces, but a quantity of excitation, a whole of accumulated energy, which acquires a painful dimension because it cannot be psychically bound or discharged and overwhelms the ego. The pleasure prism is from the outset put out of operation because the psychic system has a more urgent task to fulfill beyond the pleasure principle, namely the task of mastering the traumatic excitations. This is attempted through the mechanism of repetition compulsion in everyday functioning, in dream life, as well as the therapeutic, of course, relationship. Repetition compulsion attempts to bring the traumatic experience back to the foreground in order to connect the traumatic excitations in a way that subsequently allows their discharge and the return to the functioning of the pleasure and pleasure principle. The traumatic reaction maintains interferency is rekindled with every new experience of inadequacy of the object and narcissistic deficit. If traumatic situations are successive, the consequences are fragmentation of the personality. In these cases, therefore, we are not dealing only with conditions concerning neurosis, but with generative causes that concern psychosis, borderline states, and psychosomatic conditions. Ferenczi's reflections on trauma extend also to therapeutic technique, what very appropriate for the pathologies we discussed now. Ferenczi raises certain very basic, even critical issues of therapeutic function and the transference relationship. He modified the original psychoanalytic paradigm and cultivates a climate trust, is flexible with the frame, lenient with his patients, and monitors the transference and particularly his counter-transference for understanding the patient. Ferenczi's modifications in technique and the theoretical foundation he provided had great resonance among later and contemporary psychoanalysts, particularly in relation to the understanding and therapeutic management of severe psychopathology associated with serious early traumatization, where the tools of classical Freudian psychoanalysis are not sufficiently effective. Up to the present day, we understand negative trauma as an accumulation of energy that includes not memory traces, but somatosensory elements. That is, traces that remain very close to perception and do not enter associative chains and therefore cannot be represented. In other words, these are think presentations and not representations, which float disconnected from one another without arrangement in a non-dynamic unconscious. In this form and in this position, in a space inaccessible to the ego, this psychic material cannot become the object of psychic processing. That is, it cannot undergo ego defenses, displacements, or condensations. Being outside the process of repression, it cannot give rise to preconscious derivatives that could be taken up by the primary process and become the object of thought. Neuroscientists call these traumatic traces implicit or non-declarative memory because they are not integrated into narrative memory, as already mentioned. Without place, therefore, without psychic space, time, or history, outside repression and imaginary protective inscription, the traumatic experience is lived as an eternal present within the violence that repetition actualizes in life, as well as in the transference, counter-transfer, in the relation, in therapeutic relation between the patient and the therapist, in the transfer-counter-transfer relationship. And insofar as it does not become the object of processing, insofar as it is not transformed into a psychic event, it is repeated, it persists, and it traumatizes. The consequences of these early and severe traumatizations are reflected today in our clinical work by a shift of psychopathology toward more severe psychic disorders, namely narcissistic conditions, borderline states, behavioral disorders, psychosomatic illness, all these, as we call it, new pathologies, which actually not new pathologies, but now are presented in much more deeper and forms and in a more heavier ways. And of course, in a much more subjects, individuals, patients. So in these patients, we encounter psychic places disinvested and uninhabited by objects, deserted zones outside language and history, bodily areas where need and pain prevail and at the expense of pleasure, or even entire parts of psychic reality sacrificed to repetitive acts and behaviors. These patients present great narcissistic vulnerability. I would say that these patients present a chronic narcissistic hemorrhage. Clinical work with negative trauma is a difficult, very difficult work. Because in the clinic of negative trauma, since we are referring to early psychopathology, to psych territories outside representation, outside symbolization, pre-verbal, as revealed in our clinical work by, for example, psychosomatic symptoms or acting out, and discharge, of course, we will seek our therapeutic orientation there at the beginning of psychic life, in the first qualities of the relationship with the environment. Between therapist and patients, the transitional space will be reconstructed with the therapist functioning reparatively where the first parental objects fail. We are thus confronted with fundamental deficiencies that require the formation or the building of psychic space. With this patients in therapy, the therapist often has the sense of repeatedly stumbling against a wall, a hard, inaccessible core that his interventions cannot reach. Correspondingly, the patient himself, speaking about the existence of such encapsulations, resorts to expressions or images conveying the sense that he is separated from something by a wall or a trench. No associations comes, no memories, no material. The non-represented, because it is inaccessible to memory, historical trauma, requires transformation and construction to be articulated in speech. So it must first be represented. Thus, it is necessary to recognize that there exists a strong and imperative psychic need to historicize, to retranscribe, even to create the past by articulating psychic events, affects, often for the first time, and placing them within a narrative structure that includes historical continuity and framing. The therapist here, working at levels far more archaic than those of neurosis and repression, does not discover a hidden meaning, but constructs a meaning. The therapeutic relationship is woven as a process that touches what has never occurred in the patient's life. The reconstruction of a representational and experiential fabric and the encounter with the uncanny, deeply hidden within us and scarcely or not at all representable, is harsh and painful work. Moreover, it is an open process and not a final and closed truth. So I will stop here. I will skip all the next slides, and I will go to the last part of my presentation. Please, could you go to the slide number 26? The next one. Thank you. I skip my clinical examples, and I'm going to speculate about the neurobiological correlates of structural trauma and a brief comparison between the cognitive neurobiological approach regarding compared with psychoanalytic approach. Very, very short comments. By my vignettes, what I try to do is to show brief clinical moments where we can see what we have said up to now in various different psychopathologies. But at this point, I think the question naturally arises. How might we think about these structural differentiations in relation to contemporary findings in neuroscience and trauma research? If we speak psychoanalytically of binding and symbolizing, and neurobiologically of integration and regulation, are we describing incompatible models or parallel level of explanations? In my mind, there are parallel and parallel levels of excellence could be nowadays, because of the progress of the science, synthesized. So, speaking about neurobiological relates of structural trauma, you can see that, of course, you know that research in affective neuroscience shows that traumatic stress may involve hyperactivation of the amygdala, reduced hippocampal integration, impaired prefrontal relations. So, in case of representative trauma, the hippocampus supports narrative memory integration. Prefrontal networks gradually regulate fear responses. In non-represented trauma, negative trauma, affective activation remains dissociated from symbolic processing. Implicit memory systems dominate. Somatosensory and autonomic pathways remain hyperactive. From a psychoanalytic perspective, this corresponds to failure of binding, think presentation without word presentations, automatic anxiety, repetition without representation. Thus, psychoanalytic metapsychology and neurobiology converge on a shared insight. Trauma is not only about fear conditioning, it is about integration failure. The therapeutic relationship, when functioning as a containing and symbolizing the environment, may facilitate neural integration through relational regulation. So, coming to the last part of my presentation, a brief comparison of psychoanalytic. The next slide, please. A brief comparison. Next slide, please. Thank you. Of psychoanalytic and cognitive neurobiological approaches to childhood trauma specifically. Childhood trauma constitutes a central field of inquiry in both psychoanalytic theory and contemporary cognitive neurobiological approaches. Despite significant theoretical differences, both perspectives acknowledge that early traumatic experience exerts a profound and lasting impact on an individual's psychological and emotional development. The psychoanalytic approach conceptualized childhood trauma primarily as an experience that cannot be symbolized due to the immaturity of the psychic apparatus. According to psychoanalysts like Winnicott and Bion, trauma is associated with the failure of the environment to function as a holding and containing framework capable of metabolizing early emotional experiences. Consequently, the traumatic experience is inscribed in the psyche not as a conscious retrieval memory, but as an amorphous affect or a repetitive relational pattern, later manifested through symptoms, relational difficulties, or personality pathology. In contrast, the cognitive neurobiological approach focuses on the effects of childhood trauma on the developing structure and function of the brain. Chronic exposure to stressful or threatening environments leads to prolonged activation of the hypothalamic theory adrenal axis, resulting in dysregulation of the stress response system. Empirical findings indicate alterations in brain structures involved in emotional processing and memory, such as the amygdala, hippocampus, and prefrontal cortex. Within this framework, childhood trauma is understood as a factor that disrupts the development of effective self-regulation mechanisms and the integration of experience giving rise to symptoms such as hyperarousal, dissociation, and impaired emotional regulation. Regarding now therapeutic intervention, the psychoanalytic approach aims to create a corrective emotional experience through the therapeutic relationship, within which trauma can gradually acquire symbolic representation and meaning. By contrast, cognitive neurobiological interventions prioritize the restoration of safety and the regulation of the nervous system before focusing on the narrative processing of traumatic experience. In conclusion, the psychoanalytic perspective conceptualized childhood trauma primarily as a rupture in relationship and meaning, whereas the cognitive neurobiological perspective approaches it as a disturbance of neurodevelopmental regulation. Nowadays, we made many steps forward because in contemporary clinical practice, increasingly integrates these two frameworks, recognizing that childhood trauma is simultaneously a psychological, relational, and neurobiological phenomenon. Next slide, please. Yes, my closing remarks now. I'll skip my remarks and I'll say two sentences. The one is that the external event does not determine the outcome alone. What determines the outcome is the structural condition of the psychic apparatus and its capacity for binding representation and institution. From a multidisciplinary perspective, this does not contradict diagnostic systems or neuroscience. Rather, it adds a level of depth. PTSD describes symptom configurations. Psychoanalysis examines structural transformation. And where there's no history, we construct one. Where there is fragmentation, we build continuity. Where there is repetition, we introduce symbolization. So that was a short presentation of the psychoanalytic contribution to trauma theory. Next slide, please. Ευχαριστώ πολύ. Sorry, I cannot speak it in Ukrainian, but I write it from Google Translate there. And thank you very much for your attention.
Thank you very much.
Let me add the comment. You can share the full text of my presentation to the participants. I will send it the final form of it in the next few days, okay? And you can
Thank you, Dimitris. Thank you.
Thank you very much.
Професор Фегерт, добрий вечір. Чи ви мене чуєте?
Yes, of course I can hear you, Dr. Bulavinova. Katya, good to see you.
Дуже вам раді, професор Фегерт, скажіть нам щось, а потім ми будемо задавати питання.
Yes, I'm happy that I could come in shortly after Dimitris began his presentation. I was at a meeting of the German Family Council discussing future structures of the family in a changing world with wars, with AI and all the multiple crises and what that means for families. And therefore I was late because we had talks until 6 o'clock and I was moderating there. But now I'm glad and thank you very much, Dimitris. You know, Dimitris Anagnostopoulos is my predecessor as the president of ESCAP. He's the past president of ESCAP and I owe him very much. He really supported me very much in my presidentship, and I'm now glad that Dimitris can answer the questions. I see there are a lot of questions.
Тоді переходимо до запитань. І так, перше питання від пані Світлани Арсенюк. Які особливості травми у дітей і підлітків з аутизмом? Особливо, якщо травма повстала внаслідок соціальної взаємодії з однолітками.
Yes, this is a very, very good and very serious questions because oblige us to move from what we know from the theory and the clinical practice of the major psychopathologists I presented to you, and to think what all these could be effective, treating, first of all, understanding, and then treating autistic people, children and adults with autism. Unfortunately, let me say that psychoanalysis, psychoanalytic theory failed to produce, let's say, evidence-based theory and technique for autistic children, because maybe the older of us remember the theory of cold mother, the theory of freezing mother, and so on, which proved to be a false, very false theory about autism. And now what I can say, staying in what I presented, is that psychoanalytic framework, the way psychoanalysts thinking about various psychopathologies, helped us to have an holistic view, not only bio, not only social, not only psychological, but as I said in the beginning, not only what happened, but also what is after that, what is the internal function which governs us, first of all, our feelings towards our patients, and also the feelings of the whole family and the interaction between the whole family and the whole society with this kind. I mean, it's a very, very difficult issue that in saying about autism, what we can do. Of course, there are some colleagues, psychoanalysts, who are occupied with autism, but it's not my expertise, let me say. Because it's supposed that the autistic, the real autistic children, not the what we call now children under the autistic phasma, the autistic spectrum, have not the ability to symbolize, to understand the relationship with their self and the relationship with the others in a symbolic way, which is the big problem, which is also true for, if we speak for real autistic children. For the autistic spectrum, it's something else.
Так,
I don't
наступне,
know if
наступне питання від пана Андрія Лохматова. Чи може бути психоаналіз настільки ж ефективний в роботі з травмою, як, наприклад, МДР?
Sorry, I didn't understand the last.
Чи може бути психоаналіз настільки ж ефективний в роботі з травмою, як, наприклад, EMDR?
Yes. Yes, yes. I agree. I mean, MDR is also a very sufficient approach, therapeutic approach technique for the trauma. I think that we are not speaking about contradicting or in an opposite place theories. I think that we all examine the same phenomenon from various points of view, which in my mind are complementary. And I think that there are cases where psychoanalysis is imperative and other cases where psychoanalysis has nothing to do. I mean, we can proceed with cognitive, for example, techniques or MDR. It depends. It depends. It depends. Of course, MDR is a very efficient way of tackling trauma.
Пані Ірина Сищук питає, бойова травма є негативною психічною травмою і як її опрацьовувати?
Yes, the comments, yes. This is a great question. Thank you. As we know from the research which has already done following the Vietnam warriors, veterans in USA, we found what I tried to describe also in my vignettes, different responses from different veterans, different subjects, because it is not only the same event, it is also an issue of the psychic ability of each one. And as we already know, there was an immediate effect of Vietnam wars to veterans, which revived the PTSD syndrome again with all the descriptions and became a diagnosis of DSM-4, for example, for first time. But following these veterans in their life, after quite a long time, I mean, many years, we saw that some of them became psychotic, some of them became depressed, some of them suicide, some of them became addicted. So there is no a uniform which complies with the external events. That does not mean that external events like war, for example, or abuse, sexual abuse of a child, are of less severity or has no meaning. Of course, they have meaning, but because of these two time dimensions, in order to be in a mood of traumatic pathology, I think that the subjectivity plays a key role.
Пані Вікторія Василенко питає, якщо йдеться про психотерапію травми, чи не заважає психофарма, медикаментозна терапія, та як поєднуються ці види терапії при роботі з травмою?
There is any kind of, no, you can use pharmacotherapy, of course, if there is needed. Why not? Actually, for all kind of therapies, let me say this, and this is my general answer, which governs my clinical practice. When we speak about traumas, we are not describing different traumas. We're describing different level of analysis, different level of understanding. And when we have the actual patient in front of us, we have to be focused and holistic in their real needs. And in this way, I think that psychoanalysis gives us, let's say, a privilege. What is that? Psychoanalysis up to now is, because the oldest, the most cultivated psychotherapy theory, is the one who insists in our inner self. Oh, sorry, I have to put my laptop in the electricity. Sorry. Okay. So as I said, psychoanalysis pays attention to the interrelation between the patient and the therapist. Because if we are unable to understand inside of us what the other, our patient, project to us, say to us, not only by words, but the whole stance during the therapy towards us, we are not able to find the solution, the best solution for him. For example, I found very useful the psychodynamic, psychoanalytic perspective, understanding a clinical case in order to decide what is better for him. For example, a brief psychoanalytic therapy, a long open-ended psychotherapy, a cognitive or a behavioral therapy, a pharmaceutical, a combination of, or MDR as you mentioned before. But there is a need to have a holistic approach.
Пані Софія Піліпчук питає, чи існують способи скринінгу або риск-фактори, щоб прогнозувати, яка буде відповідь на травму, невротична чи психотична?
Yes. You mean how we can differentiate between a neurotic trauma, a trauma of neurotic origin, or between a trauma of psychotic origin? That is what you asked. Yes, we can differentiate, first of all, by the clinical conditions. I mean, it could not be a neurotic patient, the one who faces a psychotic decompensation, for example, and comes to us because of his hallucinations or visual or persecutory ideas. And there we can, we have the proper theoretical tools to understand that. For example, Melanie Klein's help us to do this for psychotic patients. There is no, you see, there is no risk factor specific, but this is true for the whole child psychiatry. Almost all our risk or protective factors are general factors and became specific in the context of the every different patient.
Пані Олена Кудаєва питає, чи є якась специфіка в роботі з травмою, наприклад, розкапсулювання травми, у людей з максимально обмеженими фізичними і психічними ресурсами, наприклад, людей з великим депресивним розладом?
Yes, of course, we can. It depends. Of course, if there is a traumatic psychopathology who underlies the depression, we can work with this patient, take into account what we are said up to now. It's not the issue of limited resources, because as I said before, I tried to say before, the psychodynamic approach, it facilitates us to confront every patient, not giving an open-ended psychoanalytic therapy to them, but because in a level of inner understanding what is going on with the psyche of our patient, we can understand his needs or her needs more clearly and to decide accordingly. And of course, it is also from the other side okay to do so. For example, cognitive side, we can gain also from this in our understanding.
Пан Вадим Ульянов питає, чи прийнятна з вашої точки зору групова психоаналітична терапія ПТСР у дітей та підлітків? Якщо так, то які переваги і які недоліки, які застереження можуть бути при формуванні групи і роботи в групі?
Yeah, thank you. Thank you. All the questions are excellent. I mean, you are going to the core of the problem. Of course, there are the group psychoanalytic theory and the group psychoanalytic therapy and techniques, various techniques, also in various different psychoanalytic approaches to groups. I'm not a specialist on groups, but I will be very cautious how to formulate the group in order to offer them a psychoanalytic group therapy. We have to be very cautious to who will include or exclude in the group in order to be the group efficient. And this is a general rule which applies to every group, not only psychoanalytic group therapies. And it depends. It depends. I think that the crucial issue is how we can define and differentiate between the different patients with the different needs. I will never offer a psychoanalysis to a patient who came to me and say, okay, psychoanalysis sounds very good. I believe to this therapy, please put me in the couch and start to psychoanalyze me. No. It's not an issue of fashion, which psychoanalysis was in fashion some decades ago when I was much younger. No, if there is no actually need and there is no actual, not only the need of the patient, but actually the ability of the therapist and to do the proper therapy, I will never accept to put someone in. And this is also true for the other ways of therapies. I mean, there is no we cannot do everything, you know, it's not any one therapy for all, and not all patients for one kind of therapy, the one or the other. That's why we must have this broad approach, in which I think psychodynamic approach and the special psychoanalytic theory of trauma is more helpful.
В нас ще є два питання. До того я відповім на організаційні. Ви вже маєте доступ до цього запису на Ютубі українською мовою. Після того, як ми закінчимо, через деякий час, скоро, доволі швидко, з'явиться також копія запису англійською мовою, яку ви зможете переглядати. Нас на всіх площадках разом було більше 360 людей, за що ми вам дуже дякуємо. Будь ласка, розповсюджуйте лінки на всі ці вебінари і на реєстрацію. Ви знаєте, що ми дуже любимо, коли ви до нас приходите. І останні два питання. І так, пан Андрій Лохматов. Травма проявляється таким чином, що при зустрічі зі схожим стимулом, тригером, тіло реагує так само, як і в моменти травми в дитинстві. Найчастіше це супроводжується переживанням сильних емоцій, коли лімбічна система набагато активніша, ніж префронтальна кора. Тому в моменті програвання дитячої травми в дорослому житті майже неможливо когнітивно усвідомлювати, що відбувається, а тому змінити свою реакцію та поведінку. Що з цим можна робити в терапії з точки зору психоаналізу?
Could you make this question more simple for me? I cannot understand
Я спробую ще раз. Зараз, одну секундочку, я шукаю. Ага, ось. Пробую ще раз. Травма проявляється таким чином, що при зустрічі зі схожим стимулом, тригером, тіло реагує так само, як і в момент травми в дитинстві. Найчастіше це супроводжується переживанням сильних емоцій, коли лімбічна система набагато активніша, ніж префронтальна кора. Тому в моменті програвання дитячої травми в дорослому житті майже неможливо когнітивно усвідомлювати, що відбувається, а тому і змінити свою реакцію та поведінку. Що з цим можна робити в терапії з точки зору психоаналізу?
Yes, it depends. Again, if someone is actually unable to work through psychoanalytic techniques, we will not offer psychoanalysis here. But if there is a possibility to work in a way that we can have the opportunity to create, as I say, a meaning through our therapeutic techniques to his suffering, we can offer, of course, psychodynamic or psychoanalytic therapy. It depends. It depends. But for example, let's say we have a child with mild retardation. There, mild retardation, mild cognitive, yes, with an intelligence, with an IQ around 70, 80. What we can do with them is not to offer, for example, interpretations to what says to us as suffering symptoms or disturbances of his everyday life. What we can do for this is just to give him a stable frame of working in his everyday needs. And this makes him to feel much, much better, because if we try in the other way, this will makes this child with the mild cognitive impairment, let's say, to feel much more inadequate to understand what happens in himself and around him in the world. And thus we will have what we usually see, the double diagnosis, as we say, child with mild retardation and psychotic features or depression or addictive behaviors. It's very, very common in this population of children.
І останнє питання. Угу.
Theory, yes, okay.
Останнє питання від пані Аліни Ігнатєвої. Чи спостерігаєте ви збільшення проявів чистої травми у дітей та підлітків, які пережили війну або вимушену міграцію? І які особливості роботи з ними?
Yeah. Excellent questions and very appropriate. Let me say that I'm also a refugee from Minor Asia. My family came from there to Greece. And I'm very, very much moved with this question. I think that what we have to do, taking into account what we said up to now regarding the psychoanalytic approach to trauma, is to make this population of children and adolescents to feel secure, first of all. To feel secure, which is not an easy task. First of all, because what is underlying in all refugees, children, adolescents, and adults, is the sense of loss, above all, and before the specific psychopathology. There is the loss of country, loss of family, loss of safety of self, and combined with the loss is the big question mark for the future, not only for the present, but for the future. So if we would like to really actually help these people, we must offer them a stable environment, a stable frame to gain and continue to live, which is not an easy task. We tried a lot, we say a lot of words, but actually, even 2 days before, 15 people drowned 300 meters from Greek coast. It's not an easy task. It's not an easy task. But it's our duty to try to offer to these people this safety. And this comes to a psychoanalytic notion of, the integrity of inner self and things like that.
Ми дуже дякуємо професору Дімітрісу Анагностопулосу за його участь в цьому вебінарі, за те, що він приділив свій вільний час, який він би міг приділити чомусь іншому, а він його подарував нам, і ми дуже дякуємо йому за це. І дуже дякуємо професору Йоргу Фегерту за організацію всього, що ми маємо в цьому циклі. І пані Оксані Збітнєвої, якої зараз з нами нема, але вона завжди з нами і дуже допомагає нам з організацією цих вебінарів. Ви знаєте, що в Україні зараз нема світла, нема тепла в багатьох містах. І сьогодні в нас була тривога, мені здається, по Києву рази 4, може, і по Львову летіли ракети. Дуже складна ситуація, і нас приємно дивує, що незважаючи на те, що нема світла і нема тепла, люди приєднуються і приходять на ці вебінари. Ми цей секрет пояснюємо тим, що професор Фегерт розповсюджує навколо себе тепло, уют і кохання. І тому люди приходять на ці вебінари. Тому дякуємо дуже, професор Фегерт. І дякуємо дуже, професор Дімітріс.
Thank you. I'm grateful to you to be with us. Let me be with us. Thank you.
Thank you.
Всім
Keep
дякуємо,
safe.
гарної тиші.
Keep safe.